you're all welcome to the RISE Project Rwanda Clinical Case Series. Today, we're going to be discussing COVID-19 diagnostics and therapeutics. And while I think we all understand that we have all been living this pandemic for the last 2 years, what is true now more than ever is that we have more tools, more resources to be able to manage COVID-19 patients. And given the input of oral therapeutics, rapid testing availability, today is a very important topic as we discuss COVID diagnostics and therapeutics to understand how they apply to your clinical setting and also how they potentially could apply to future test and treat programs. So we're going to be joined by a very esteemed group here today. From Johns Hopkins University, we invited Dr. Matthew Robinson. He's assistant professor in infectious diseases. And then from CHUK, we have Dr. David Turatsinze, who is a specialist internal medicine and the co-lead for the case management of COVID-19 National Task Force. And Dr. Vincent Ndebwanimana, who is an emergency and critical care physician at CHUK also, and is a consultant for the RISE project. I'm going to be your guide on today's journey. My name is Dr. Bhakti Hansoti, and I'm an associate professor in emergency medicine at Johns Hopkins University. I'm also the technical director for the RISE project. So, I want to give, since this is our inaugural session, I have some esteemed guests that I'd like to welcome. And I also want to just take a quick moment to share with those of you who may not be familiar about the RISE project. So RISE is a global mechanism that is a cooperative agreement which is funded by USAID. And we've been working on supporting countries for the COVID-19 response for the last 20 months. We have 3 areas of focus. The first is clinical case management. The second is oxygen ecosystem strengthening. And the third is vaccinations. And we have experience from everywhere from Afghanistan to India to Mozambique. And we are honored to be on this journey with our colleagues in Rwanda who are doing a phenomenal job. The RISE Rwanda team in particular is focused on 2 objectives. The first is supporting the rollout of COVID vaccinations, and the second is strengthening COVID-19 case management. And these activities are led by our country director, Mary Rose Kirawanga, and Dr. Eugene Rugwizangoga. I apologize for the pronunciations, Eugene. I think when I visit you in country, you'll have to teach me how to do a better job in the future. But please do not hesitate to reach out to these colleagues in Rwanda if you have any suggestions on how RISE and the Rwanda team in particular can support your efforts in managing COVID positive patients within health facilities. And nothing is possible without partnership and engagement from our colleagues in the Rwanda Biomedical Center and the Rwanda Ministry of Health. And I'm just very, very excited to introduce this team to a special guest. We are joined here today by Dr. Edson Wagasore, who is the Division Manager of Public Health Surveillance and Emergency Preparedness at the Rwanda Biomedical Center. And we're also joined today by our Activity Manager at USAID, Dr. Richard Munyanesa. So I'm going to first offer the floor to Dr. Wagasore if there is anything that you would like to say before we get started with this case series. Dr. Wagasore?
Yes, all right. Thank you so much. Thank you, Bhakti. I don't know if I pronounced your name well. And thank you all. Thank you also. I would like to really thank Jhpiego, USAID for this great innovation, bringing together healthcare providers and improving quality of care. So Rwanda has been has faced or moved within different waves, and in all waves, case management has been a pillar and playing key role to ensure that they mitigate the burden of of disease within the country. And since we are now moving out of this wave, Omicron, which has been driven by Omicron, it's now time to reflect on really what needs to be improved and learning from the best experience and best practices from different countries. So I strongly believe that with this platform, we'll be able to learn from different experts from Johns Hopkins and see how we can improve the care of our patients within the country. So I'm really looking forward to learn and also support other healthcare providers within a decentralized level, which really understand that we play a key role in case management. We are now working on one of the strategies and updating our new strategic plan. And still, the case management will remain and remain as a key pillar that will drive or will mitigate the burden of COVID within the country. So I've just looked at the topic and I see it's very interesting. And let us hear from experts what they share with us. Thank you.
Thank you, Dr. Wagasore. And, you know, we are just so honored to be working in partnership with the Rwanda Biomedical Center. I think together we can identify innovations and strategies, not only to support Rwanda, but to support other countries in the region as well. And RISE is just very excited about this partnership, and thank you for giving us the opportunity. So to move on to today's learning objectives, and I don't see Richard on the line, but Richard, if I'm missing you, please just unmute and interrupt me, please. So to move on to today's learning objectives, we have a pretty straightforward session. We want to understand the need for early diagnostic approaches for patients with COVID-19, to describe the therapeutic escalation of patients with COVID-19, and really sharing some of the protocols and the experience that we've had here in the United States, to summarize a holistic approach for care for patients with COVID-19, and to support clinicians on this call to develop the very important skills and knowledge to implement case management interventions. You know, and we'll discuss this as we continue, but one of the real things is how can we abate the strain on the health system of COVID-19 by improving access to test and treat and decentralize the care that is needed for clinical case management. And so I think this is a journey that we will all do together. And I look forward to seeing how this conversation generates implementation plans and activities within the health facilities that are represented on this call. And this is going to be the first of many calls, right? So this is just a venue for us to share ideas and learn from each other. So you'll see that reflected in the session outline. To orient us to the topic and the clinical problem at the forefront here, we're going to have a clinical case presentation, and this will be led by our two Rwandan colleagues, Dr. David and Dr. Vincent. I then invite all of you to participate in an open discussion for about 20 minutes, and we'll split the answers and questions between both the Rwanda colleagues and the US colleagues, and anything can be asked in the session. And then we're going to end the session with a summary of the current evidence base for COVID diagnostics and therapeutics available, updating all of us on the latest evidence around COVID-19 clinical case management. We'll have a couple of minutes of wrap up, and I recognize that everybody is very busy, and this is also late in your afternoon, so we aim to end on time. So without further ado, I'm going to stop screen sharing, and I'm going to hand it over to my colleagues in Rwanda to discuss the clinical case. Dr. Vincent and Dr. David, the floor is now yours.
Good afternoon, everyone. Good morning to the colleagues in the United States. Can you all hear me? Okay.
Yes, we can.
Thank you very much. Thank you, Prof. Hansoti, for the brief introduction, and importantly, welcome all of you on this important brainstorming on COVID. So I was given an opportunity to present the case and thereafter have inputs by the experts from the USA. But before anything else, I would definitely would like to thank the RISE project team and importantly, Dr. Edson, who has been in everything in as far as case management of COVID is concerned. He's given his best, and surely we do appreciate. We needed people like him. And so my role today is to go through the case. I think the participants will keep joining. We have a couple of them. I see the number is increasing over time. So maybe we should start as they join. Can you all see my screen?
Yes, sir. We can see your screen. It is in slide view. If you could change it to presenter view, that would be great.
Yes, I'm going to do just right that. Is that more better? Is it readable? Can you read the slide?
Not really.
Yeah, not really.
Then I have to stop my video and see if you can comment. Okay, so on the screen now, can you see it?
So David is still in slide view and not presenter view. Would you mind trying one more time to press the presenter view button?
Just wait.
David, can we have Linda share the slides for you and then maybe just say next slide as you present?
Okay, if that's possible, but I was just going to do what you had asked.
Okay, good. Why don't you try first?
Then that's good. Okay, let me do that.
Do I see a couple of hands raised while we're waiting for
Can
David
you see it now? Can you see it now? Even now? Oh, okay.
Linda, please.
Still now you can't read the screen?
No, but it's okay. We have the slides up because Linda is sharing.
Okay,
can you
cool.
proceed to the case?
Okay, can she share then so that everyone would be accessible? I'll be having the opportunity to tell her to proceed on the next slide, if that's fine.
It's now okay, we can see the screen.
You can?
Yes, I can. HPI,
Yeah,
that's cool. Right? Yeah.
All right, thank you then. So I'll start. You know, like any other country in the world, Rwanda also had a big number of positive cases, and definitely the statistics from the WHO website also indicate, like any other country, that we did lose so many patients as well. And unfortunately, one of the cases that I'll present, since this is a brainstorming session, I will have to apologize that this is a patient that passed away during the course of treatment. So he is a 59 years old gentleman, was admitted to our emergency unit with all those features, typical manifestations of COVID, with dyspnea, fever, cough, of course, had tiredness and sore throat. We all remember right from the beginning of the pandemic, these were the most common features that we were told and we could see with the patients. So upon asking the patient and the caretakers, they say the above symptoms had actually lasted for over 7 days. Next, please. So on further interrogation, though the patient was really struggling to breathe and construct sentences, he narrated to us that he had not used any drugs, be it substance abuse, had no other past medical history of note, no previous surgical, and he did, however, report that he had a smoking history, and he reported that over the few days he had been in contact with a patient that was diagnosed COVID positive. Next. On examination, he was weak and struggling, as I said, to complete a phrase or otherwise a sentence in completion, because every other time he tried, he would not complete because of the shortness of breath, and you could see the chest expansion. I mean, we all agree that the physical examination, when we dressed into the coveralls, is not that perfect, but we tried anyway. And in terms of physical examination, neurologically, he was okay, apart from the muscle weakness, the cardiac, the abdominal, the locomotor systems were all normal on physical examination, but had balanced crackles in both lungs. Then he was, of course, conscious. As I said, the neurological examination was good. And vitals, the blood pressure was 128/70 millimeters per mercury. The heart rate was 123. You surely can see that was pretty fast, 123 per minute. And the body temperature was 39.3 degrees Celsius. That is also high. On using a saturometer, the patient's respiratory rate, sorry, here I think it's 18. The respiratory rate is 18, not 88. The SpO2 is 88 on room A. And so I corrected the last one that I sent. It is 18, not 88, the respiratory rate. Next, please. So then we had to keep the patient, and we performed a couple of examinations. The whole time, I think we all were suspecting COVID, and the RT-PCR became positive for COVID-2. And then we also did a monitor with an ECG, which displayed atrial fibrillation with rapid ventricular response. Next. We did an X-ray, and it according to the radiological definitions of COVID, they were so confident that it really fell into the criteria. He had bilateral patchy areas of ill-defined lung opacities and consolidation, and that's in most cases peripheral. That's what we've seen commonly on COVID. And we performed a CT chest that was also in keeping with COVID typical ground glass opacities. And further investigations, we did blood tests, and I did put a table at the end that we shall go through, but initially the blood tests revealed a decreased white blood cell count, and also the lymphocytes were low in number, but the CRP was very high. Please take note that we don't do the PCT, and the literature has revealed that the ESR does not actually give any differentiation from the CRP. Next. So we actually had started the low dose oxygen while performing all those investigations, because when we transported him to the CT scan, we had to use a cylinder, and we only started with 2 liters per minute. The SATs improved from 88 to between 92 to 94. And then it looked though after the CT scan, he wasn't coping with 2 liters. So he, I don't know if it's related to the transport or the way we had to transport him for the CT scan. Since we don't have the portable scans, he developed severe respiratory failure. And on day 4, he was actually worsening. So we moved from 2 liters to 10 liters. And on day 4, he couldn't cope with 10 liters, and we transferred him to HDU, where a decision to ventilate him was agreed on. Next, please. So from the beginning, before even day 4, when we decided to intubate the patient, we gave the gentleman azithromycin, that's a macrolide that we do know. And we also used tocilizumab, and we gave the neutralizing monoclonal antibodies, which is an infusion, 1 dose. The temperatures, as you saw, were high, so we also used dexamethasone. That is a steroid that was also has been advised to be functional. And the blood gas by then in HDU did show severe hypoxemia with a very, very low pH. And of course, the bicarbonate as well was supportive of his acidosis. Next. So the chest on day 4 in HDU, we were not able to, did we jump some slides? No, I think, okay. So we really wanted to benefit from the CT chest, but it was difficult to perform a CT chest looking at the patient on a vent, and the way we struggled even to transport him on the first day. So the patient passed on the 14th day into respiratory failure. Next. So that's the overview of his blood results, looking at the white cell count from day 1 and until day 14. It was typical of, you know, a high flow because we had put the patient on antibiotic steroids that definitely could have had an impact. He had a stable HB and platelets, and looking at the differentiation, there's also the liver enzymes were a bit constant until the last days when they were shooting up in keeping with severe sepsis. However, the renal function was also intact, but looking at the CRP, that really shows how high, how septic the patient was becoming. Next, please. So that is the X-ray. I tried to get the X-ray on day 1, but I couldn't. But this is the X-ray we did on day 4. It was worsening. You could see there's definitely increased opacifications and what we can call more peripheral, even going into the central. We thought at some point there could be an association with pulmonary edema, so we started also diuretics, which are recommended. And please go on. Next slide. So that is the CT scan. That is the CT scan. And you can all see the typical opacifications in the peripheral regions. All these and they. So next image for the scan. With that, sorry, no, the previous one. The previous one, please. Yes, with that, with the whole team, we suspected this is more much in keeping with ARDS. And as I said, he was already on a massive list of medications, and unfortunately, on the 14th day, we struggled to save him, and he passed on respiratory failure. Next slide. Next. Next slide, please. Yeah, so that's an image in one of the literatures of COVID that does show the typical COVID spread in the lung and the pathophysiology of lung disease until ARDS. Sometimes when it is into ARDS, then saving these patients becomes a bit difficult to have these patients saved. Yeah, so that's in brief the whole clinical case, as we said. If you can go on the next slide, then there's a list that I made of medications that we used in Rwanda. I think Professor Robinson will also share with us if there are some that we miss or we overtreat, probably. So in our settings where we would confirm severe disease, we use dexamethasone, tocilizumab, azithromycin, and then the monoclonal antibodies as well, and etesevimab. There's in some cases where we had to mix both BAM and ETE. So with this list, in early phase of disease where we don't have to need oxygen, we used favipiravir. We did also use azithromycin, broncholytics in some patients where they were needed, and also antipyretics. So looking at that patient and the whole clinical picture that I've shared with you, we were very happy to, of course, have an opportunity and hear what Professor Robinson would have done otherwise in terms of the different approach. I thank you, all of you.
Thank you so much, Dr. Turatsinze. So I'm going to ask the speakers, the panelists, to come on camera if you have bandwidth that will allow you to do so. So we have, in addition to Dr. Turatsinze, we have Dr. Matt Robinson, who I'm just trying to find. There you go. I'm going to pin you. It's not letting me pin multiple people, actually. So let me just try and remove this. Linda, I'm going to ask you to just pin the 4 speakers, if you can do that in the background. But let's get started because we have some really great questions and in the chat already, and some really good discussion to be had. And, you know, David, I just want to outline that, you know, this is really all teach, all learn. And I think that learning here is bidirectional, because I think the patients are different, but also seeing, you know, I think the purpose today is not to really see how we could have done things differently, but to see how the pandemic is evolving, how the clinical scenarios are evolving, and how our management should evolve. So, you know, I want to start with a really big picture question. And I think this one is for Matt. You know, I know that you've been seeing these patients here at Johns Hopkins University also. How is this clinical course that we saw, like a very stable patient on day 1, then rapid deterioration at day 4 to death on day 14? Is that still what we're seeing in our ICUs and our high dependency units? Or what is more typical nowadays of the COVID-19 patients?
A great question. You know, I think this patient's clinical course is relatively typical. You know, I know that when he presented, he was only mildly hypoxic, but, you know, many patients with COVID do deteriorate relatively quickly while hospitalized. we find that almost all the patients who eventually go on to requiring mechanical ventilation do so within that first week of presenting to the hospital. I think nowadays at Hopkins, we have very few cases, but like a month ago when we were at the tail end of the Omicron wave, we were seeing a mix of unvaccinated persons presenting similarly to this, and vaccinated persons with a lot of comorbidities presenting a little bit differently.
Thank you so much, Dr. Robinson. Dr. Vincent, so like me, you're an emergency physician, right? So we see all of the people that come through our emergency department. So I think I have like two questions for you. The first is, like, in the emergency departments, do we have access now to some of the newer therapeutics for patients with less severe illness but high comorbidities like Paxlovid or molnupiravir? And the second question is, what strategy are you using in the clinical area to differentiate between patients who are going to get sicker and deteriorate and need some of the other therapeutics such as remdesivir versus those who are stable perhaps to go home?
Thank you very much for the great question. As usual, the COVID-19, which is a highly contagious and a condition which leads to a clinical deterioration, has been a big challenge for ED settings, starting from the triage or recognition of the diagnosis versus the consideration of the therapeutic options. So for us, the practice has been the focus on early recognition of the diagnosis and the accessibility to the triage. I'm working in a referral hospital, has been accessibility to different options of the treatment has been there. And we were able to initiate any therapeutic, especially that the therapeutic option were not immediately focusing to COVID-19 until we get the rapid test where we can get like to know at the first time, oh, this is COVID. Of course, even for other settings, if you confirm COVID, it doesn't rule out other conditions. So we have been broadly approaching like association of antibiotics, ruling out other conditions like pulmonary edema, tuberculosis, like I'm sure that some of the diagnoses have been missed due to the finding of COVID. So that has been our practice, early detection and consideration of differential diagnosis and rule it out or ruling in it by one. That has been our practice. Thank you very much.
Thank you, Dr. Vincent. So you put the question in the chat, and so I'm going to give it to your colleague, Dr. David. And the question really was, in the Rwandan context, what else is on our differential diagnosis that clinicians should be considering? And I may add a second part to that, is what comorbidities should we be evaluating for during the initial evaluation so we can identify patients who are going to have a poor outcome? Dr. Turatsinze?
Thank you very much. So it's a very good and very important question, but a little bit on what Professor Matthew mentioned. This patient is actually an old case, and this was a case of 2021 in April, and that was the phase of Delta, where, of course, Delta and severity were matching. So, and the vaccination coverage by then in our country was so low. So our patient hadn't actually received any vaccine. And the progress of disease was typical of Delta. We weren't doing systematic sequencing, but the Omicron is a new variant of recent. So going back to access of therapeutics, yes, we did have by then. I think we started with a different therapeutic approach in December 2021. So at some point, yes, we did. We did not have as you have in the USA, but at the point, I would say we had what was supposed to be used. And then regarding the differentials in the Rwandan context, this side of the world, there is a possibility of TB, as he mentioned. There is association of PCPs or PCGs, if I may say, in association with HIVs. We do have a very small number of patients that smoke, but as I indicated, is a smoker, so we could be also looking at other underlying lung diseases. So that's what we normally outline regarding the history taking and, of course, looking at what could be the association into COVID worsening. I don't know if I've answered your question, but thank you, and over to you.
Thank you so much. You answered it perfectly. And I'll tell you that this is a cheeky question, because I personally, my research is focused on HIV in the emergency department. And I really wonder if routine diagnostic testing for undiagnosed HIV, diabetes, hypertension would actually be really beneficial in settings for individuals who don't normally come to the emergency department or the health system. And maybe that's something we can discuss in the future. Dr. Adamu in the chat has put a question. He said, what happened at day 4? It seems like, patient was stable day 1, and then day 4 made a deterioration. And I just wanted to ask Dr. Robinson to comment on, could there have been a possible secondary infection complicating the clinical course? Now, it's obvious that the patient developed ARDS, but what should we be thinking about in terms of secondary bacterial fungal infections, and should our empiric management of these patients be modified?
I think that's a great point to consider in this case. I think one of the key things to look at is the white blood cell count during the course of the patient's illness. When they presented, they had a relatively low white blood cell count, which is typical for COVID. But towards the end of their hospitalization, their white blood cell count increased at a time when they had worsening infiltrates. And also we have to remember this patient received tocilizumab and steroids. So, I think it's very possible that in this case, a secondary bacterial or fungal infection could have contributed to the patient's worsening respiratory failure and demise.
And Matt, my second question, which you didn't answer, was...
I want to comment on this. This is very typical presentation of common in our settings, not only in our settings, but all the patient. If you look to this patient on the first day, under supplement of oxygen with 2 liters, he was not saturating adequately. The saturation was still ranging between 88 to 90. And remember that most of our patient, COVID patient, they would come with severe hypoxia. Saturation, you would be surprised if it was a patient, the baseline would have been like in the 30. So in 30% or 40 or 50. So you wouldn't be surprised to have this patient deteriorating so quickly. I'm sure that you have seen the imaging, which was also showing lung injury. So the point here is that always, out of the wave or not, don't disregard the vitals of the patient. Being saturating on 2 liters, does the patient really need a close monitoring and keeping the eye on them? Otherwise, they can surprise you.
Yeah, I just want to emphasize that point about the vital signs. At the beginning of COVID, we used to send all kinds of inflammatory markers in all of our patients. We realized, though, that if you just look at the ratio of supplemental oxygen to pulse oximetry, the SpO2 to FiO2 ratio, that is far more predictive of the trajectory of COVID than any biomarker, even fancy ones like IL-6.
Thank you, Dr. Vincent and Dr. Matt. A quick question for the group, and then I want to shift a little bit, is would starting empiric antibiotics or antifungals be something you would consider in a patient who is deteriorating, has persistent fevers and an elevated white cell count? And what would those antibiotics or antifungals be?
So I think that when a patient first presents with typical COVID, I think it's important not to prescribe empiric antibiotics because that can actually increase your risk for bacterial and fungal infection in the later course of the illness. Once the patient did develop, worsening respiratory failure with a rising white blood cell count, I think it is appropriate to start empiric antibiotics. And I would do that according to what you would normally do at your institution for a hospital-acquired pneumonia.
Dr. Vincent, can you comment on what the current standard of care for empiric antibiotics would be in the Rwandan setting?
In our settings, unfortunately, there is increased rate of antibiotic resistance. And I'm sure that there is a great consideration of considering if this was a patient with recent history of hospitalization, yes, you need strong antibiotics to cover hospital-acquired one. But if this was a patient coming to the community, I would consider community-acquired pneumonia and starting like amoxicillin clavulanic acid, something IV as an option. And again, as Matt say, and the practice, this has been a broad challenge. Remember that, as I mentioned, this has been a COVID patient, but there would be some co-infection with bacterial infection. So it's all about clinical judgment. And I don't want to say that there is, like a specific guidelines when the patient come in, start empirically the antibiotics. So it's something to consider. Of course, look on the clinical status, like the underlying condition. Was it someone who is immunosuppressed? So this is something to consider in your mind. I would leave that to the clinical judgment, but also if someone is continuing having fever, deteriorating, increased inflammatory markers, definitely the consideration of antibiotics would be recommended. Thank you.
Thank you so much. So last question, and many of our astute colleagues have noticed that the hemoglobin was rising. It started off at 15.8 grams per deciliter to 16.2. Dr. David, would you care to comment on the hemoglobin in this case? And is there significance of that hemoglobin?
All right, thank you very much. I'll start with that. I think the rise in hemoglobin, of course, could be related to the infectious process that is going on as well. But look, I think I mentioned as well that we did start corticosteroids from the beginning. So the pattern could be associated with that. It's very unusual, but the mark in increase is not that much significant. So I didn't put a comment on it initially in the presentation. But looking at what Dr. Vincent just mentioned, I think it's also in the slides. Antibiotic therapy are subjective to the treating doctor, but we have a protocol as well from the national guidelines that at least if we are suspecting COVID, even in an acute or in stable disease, always associate a macrolide and in our rural areas, you do not find the macrolide. So there is substitution with doxycycline, which is so commonly used into this region, in the SADC region. And then you also look at, COVID can give you about 3% GIT complications. So if you look at it and say, no, I'm pushing in like augmentin, then you're exposing the patient to further GIT complications. So we decide, do I go second generation cephalosporins? So that was physician judgment. But overall, like all the antibiotics did contribute. We even escalated doing blood cultures to see, are we not dealing with different bugs that could be, coming in because of COVID. Yeah, so yeah, it was a bit challenging, but I think now the literature is becoming richer and richer and very helpful. Thank you.
Thank you so much. I could continue talking and asking this group of experts questions all day long, but I do think we should move on to the evidence-based review. So as Matt gets the slides together, I just want to share with our participants today, a recording of today's session will be made available to all of you. If our presenters are willing, we'll also share the slides with you. And then Dr. Turatsinze, I recommend that we also email out the latest clinical guidelines. As with COVID, our guidelines constantly need to evolve. My takeaways from this case are, this patient came in somewhat stable. Consider the risk of secondary infection, which may propagate deterioration. Think about how frequently we need to monitor patients, and perhaps the SpO2 to FiO2 ratio is a really great tool for you to identify patients who are going to have increasing severity of illness. So I'm going to hand over to Dr. Robinson and thank our Rwandan colleagues for joining us today. This was a very informative and meaningful discussion.
Thank you. So I have 10 minutes to talk about all the evidence for COVID diagnosis and treatment. So this is going to be a little bit brief. So I'll talk about the performance of diagnostics by disease phase, the application of those diagnostics by their setting where they should be used, the phases of COVID, antiviral therapies, and immunomodulatory therapies. I think the group is maybe more interested in therapies, so I'll go fast through the diagnostic section. So when we think about diagnostics for COVID, it's important to think about where a patient is in their disease course. So before patients become symptomatic with COVID, they will have detectable viral RNA, which can be detected by PCR tests or other nucleic acid tests. Then around the time of symptom onset, as virus increases, it is then detectable by antigen testing, although the limit of detection is higher than it is for RNA, so some cases will be missed. The threshold for transmissible SARS-CoV-2 is approximately where antigen testing level of detection begins, although it's not perfect. As disease progresses, the initial tests become negative. Antigen testing beyond the first week is usually negative, but it can remain positive. About a week into disease course, antibody response picks up and IgM and IgG can be detected. But because of this, it's not really a major component of testing for COVID, really more to document prior infection or vaccination. So I'll skip ahead to this. So I just wanted to show here that in the beginning stages of COVID, we start off with viral replication. When we get about a week into disease, the viral replication starts to taper off, and then the body's immune response kicks in. So when patients progress to more severe disease, it's often in the setting of a patient's inflammatory response increasing. Now, there's caveat to this. For patients who are immunocompromised, they may have a delayed or absent inflammatory response, and the viral replication phase can continue for longer. This is important when we consider the types of therapies that are available for COVID, because as we progress farther into disease course, therapies that are directed against the virus are less likely to be effective because disease is at that point more modulated by the inflammatory response. So I'll talk briefly about the different antiviral therapies that are available for COVID. So I've listed a bunch of different things here. The first three drugs are sort of direct antivirals. They're small molecules. They're in some ways similar to antiviral drugs that we use for HIV. Molnupiravir and remdesivir are basically nucleotides that are similar to the ones that the body uses, but different enough to mess up viral replication. So what I have here is the drug in the first column, the setting where it's appropriate for use, the symptom cutoff day, after which it's unlikely to be effective. And that goes back to that point I mentioned before about the beginning phases of COVID being driven by viral replication, which then tapers off. And then I have here a key efficacy measure from a trial. And then the last column shows some challenges and caveats with those therapies. So the first two drugs are relatively new, only became available in the US at the very end of 2021 or the beginning of 2022. And I'm unsure how available they are in other settings. So molnupiravir and nirmatrelvir and ritonavir. So this second one is the generic name for Paxlovid. Both were studied in the outpatient setting with endpoints of hospitalization or death. The Paxlovid, nirmatrelvir and ritonavir, I still can't say that name right, it showed an excellent relative risk reduction for hospitalization of 88% in that trial. The trial for molnupiravir did not show quite as strong of a response to therapy with only a 31% relative risk reduction. It's important to note that you can't compare these numbers between trials because in many cases the variants were different, the settings were different, but I think you can get a general sense of the effect. Molnupiravir, the main challenge with that though, it works by messing with the viral's ability to reproduce faithfully. And so it causes mutations in the virus, which makes it more difficult for it to replicate. But there's concern that that can also cause birth defects in people who are pregnant and the potential to cause malignancy in others. Although that malignancy hasn't been shown in any of the trials, it's more a theoretic risk. The Paxlovid works very well. The problem is ritonavir interacts with many drugs. For those of you who are familiar with treating patients with HIV, I think you will already know the challenges of prescribing ritonavir. Remdesivir is the first antiviral drug that was available to treat SARS-CoV-2. We started using it most in the inpatient setting, but trials have been very mixed for its efficacy in the inpatient setting. And because of that, the WHO had recommended against its use, although it is still used in the US. In the outpatient setting, it is very effective at preventing hospitalization, but it's an IV therapy, so it's really not very practical for outpatient use. It can be given over a 3-day treatment course and is very effective at preventing hospitalization, though, if it can somehow be given. There is some retrospective data that shows a reduced risk of progression to severe disease in patients who are not already severely ill. The problem with any of these antiviral therapies are that patients are frequently presenting to the hospital once they're already crossing into that inflammatory response phase. So antiviral therapies are less effective. The next two things on this list are the monoclonal antibodies that we've used most in the US. There are a few others that I was unable to fit on this list. I'm not going to talk about the bamlanivimab or the casirivimab because they're not effective against Omicron. So the only one we're still using now is sotrovimab, which is also really an outpatient drug shown to reduce the risk for hospitalization in outpatients. None of these monoclonal antibodies have convincingly showed improvements in outcome for inpatients, although there may be caveats to immunocompromised patients who are unable to mount an immune response. Convalescent plasma has been studied in many studies, and there are wide estimates of its efficacy, ranging from many studies which show no efficacy at all to some showing efficacy that nears some of the monoclonal antibodies. The key thing to note here is that if it's possible to test convalescent plasma for its high titer and make sure it's from a more recent infection, as the variant that the patient was exposed to generate the plasma should really match the variant that the patient hospitalized with has. For immunomodulatory therapies, these really should only be used in patients who are requiring supplemental oxygen. Dexamethasone is the best studied, which shows a 17% relative risk reduction in death. Tocilizumab, which this patient received, has a lot more caveats, and it really seems to be most helpful in patients who are rapidly progressing towards requiring mechanical ventilation. Baricitinib is another one that is out there. We've only really used it as a backup for tocilizumab if there's a reason it can't be used. I'll stop now to see if there's any additional questions.
Matt, you have 2 minutes to spare. I don't know how you did that. That was like very, very, very concise. Any comments, questions from our panelists or others in the audience? And please feel free to come off mute. Thank you so much for such an enriching discussion. And I really look forward to an update in 3 to 6 months when the drugs that you'd mentioned at the top of your table, molnupiravir and Paxlovid, I'm not also going to try and pronounce it, are going to be more broadly available on the global market. I think it's nirmatrelvir and ritonavir, FYI.
Yeah, nirmatrelvir. I still can't pronounce it right.
Matt and I can spend all day just trying to pronounce drug names on a slide. So do we have any questions from our colleagues? Well, I'm going to wrap up promptly then. I'm going to just say thank you so much for our esteemed speakers. It's really great to see the knowledge and expertise across the 2 different institutions. And we look forward to delivering the next session. Linda and Valerie, could you please just put into the chat what the next session is and when the topic, the time and date. For those of you who are registered for this session, you should automatically receive a calendar invite so you don't miss any of the future learning events in Rwanda. Okay, I think we will end. Thank you so much to everybody. And feel free to come off mute. I'll stay here for a few minutes if there's any lingering questions. Oh, Matt, there is one question here. What about, do you want to go for it? You can pronounce that drug name.
Yeah, so I mean, that one we don't have access to in the US, so it's been less studied. I don't think there is as much evidence to support its use.
I would agree. I think there were several clinical trials in India which showed limited efficacy. Its use for the Omicron or the Delta waves was not proven to be effective. Okay, next session is going to be a mechanical ventilation for COVID-19. Take care, everybody, and have a very blessed day.